All right, let's do case number 1. A patient had a bilateral knee prosthesis, or K-Pro, implanted during a single trip to the OR. The left K-Pro incision was at 8:23 and closed at 9:50, and the right K-Pro incision was begun at 10:03 and closed at 11:33. Which statement is true? No, I can't. I can't tell if this is enabled or not. I guess this one's not an audience response. Okay. Or you can push the button if you want, but but it won't help. So, do you think that it's number 1, 1 K-Pro procedure should be reported with a combined duration of 2 hours and 57 minutes? Or number 2, 2 separate K-Pro procedures should be reported, each with a duration of 2 hours and 57 minutes? Or door number 3, 2 separate procedures reported, the left with the duration of 127 and a right with the duration of 130. Door number 3? All right, you win the prize. That is correct. It was an audience response. Oh, I see it here. Well, thank you to the 30 of you who voted. Most of you got it correct. All right, I don't know why I couldn't tell that. Okay, so it's number 3. Okay, so the rationale for this, as you recall, we talked about how to handle bilateral operative procedures, that we need 2 separate records for each of the procedures, and then for documenting duration, you indicate the incision time to closure time for each procedure separately, and if you can't, you just take the total for both and divide it by 2 across the 2 procedures. Let me get to one, and I'll let you know. Okay, let's do case number 2. On June 18th, a 45-year-old male had a colon resection. On 6/22, the patient's abdominal incision has purulent drainage from subcutaneous tissue and slight erythema and induration. The incision is intact. Wound drainage specimen is sent to the lab for culture, and it comes back on 6/24 growing Enterobacter species and E. coli, and the patient on 6/22 is started on antibiotics. All right, this is an audience response. So what should be reported to NHSN? 1, nothing. Surgeon didn't open the wound, so the criteria are not met. 2, nothing. It's an SSI, but not an HAI. 3, it's an SSI at the superficial incisional primary site, or a SIP. Or 4, it's an SSI it's a deep incisional at the primary site. Okay, so it's the clickers. Okay, you almost done? I've only got 81 responses. Okay, a couple more seconds. All right. And the answer? Most of you said number 3, and that would be correct. Very good. Excellent. So let's look at why. So this is the new, for 2013, definition of deep incisional. And we've got an infection that occurs within 30 days, right? We had only the skin and soft tissue that was skin and subcutaneous tissue that was involved. And then we had purulent drainage as well as a positive culture from the spot. So it actually meets more than one criterion. Okay? All right, let's do number 3. This is also an audience response. Patient is admitted to the hospital on April 12th for elective surgery, and an active MRSA screening test is positive at that time. On the same day, the patient undergoes a total abdominal hysterectomy, or a HIST. The postoperative course is unremarkable, and the patient is discharged on 4/16. On 4/29, the patient is readmitted with complaints of acute incisional pain since the day before. The surgeon opened the wound into the fascial level and sent drainage specimen for culture and sensitivity. On 5/1, the culture results are positive for MRSA. Is this an HAI? All right. Since everyone shouted it out, we'll just go there. Very good. All right, and what do you think should be reported? This is a voting question. So. Okay, I've only got 68 responses so far. Somebody push the button. Okay, you ready? Ready. All right, most of you said number 3. Which is a deep incisional primary, and whoops, that would be correct. Okay, let me just do that again. All right, so deep incisional at the primary infection site. So there's the, this is why we have an infection that occurs within 30 or 90 days based on the type of procedure, and this is a, this was what? A hysterectomy, and we know from yesterday or from earlier today that that's going to have a 30-day follow-up. It was involving the fascial level, and we had a deliberately opened wound that was culture positive. And in addition, we had localized pain and tenderness, so it meets that criterion B of the deep incisional. And it's at the primary site because there's only one incision, right? And that's always the primary one. Any questions about that? Okay, great. Good job. What is the date of the event for this one? This is not a voting question. So I heard 4/29, I've heard 4/28. Somebody said 4/12. All right, so let's take a show of hands. How many think it's 4/12? How many think it's 4/28? And how many think it's 4/29? Okay. So the winner is 4/28 because that was the date of the first symptom. So let's go back. So right here, she's had the pain since the day before. All right? All right, does everybody see that? All right, that was a little trick. And then again, this is just shows you in the table of instructions, again, how you're supposed to report the date of event. It's the first clinical evidence or the date the specimen used to make or confirm the diagnosis. Okay, let's move on to case number 4. We have a patient that had a total hip arthroplasty, or an H-Pro, performed on March 17th at Hospital A. The patient was discharged from Hospital A on the 19th of March. The patient was admitted to Hospital B on the 25th of March with purulent drainage from the superficial incision. Further investigation concludes that this is a superficial incisional SSI. What should Hospital B do? Notify Hospital A that they've got one of their infections. What should Hospital A do? Report the SSI to NHSN if that's one that that Hospital A is monitoring. What if the infection became apparent 35 days after this procedure? It would not be considered an SSI, correct? And therefore it would not be reported. Ah, okay. So we have some people that are confused about why that is, so let's look at the rationale. We always associate SSIs with a particular procedure through the linking, and we talked about that, and with the facility in which the operation was performed, in this case Hospital A. I think you all got that. But remember, superficial incisional infections are only followed for 30 days. All different procedure types. For every procedure type, if the infection's a superficial incisional, it's 30 days only. So if it shows up 35 days later or 31 days later, you don't report it. Okay? Is that clear to everybody? Now, if you tried to enter that record into NHSN, it would get rejected because we do have some business logic in there, if you're following it in plan, that will not allow you to save that record. But save yourself some time and try to remember that one, so you don't have to work it up fully if it occurs more than 30 days out. Okay? Good. And this is just a screenshot of linking. Remember I told you that, well, I just wanted to make a plug actually for our help messages and our help system because there's a lot of useful information. So if you're in the application, you can click on help system, and if you go to procedure associated module and then to how to and events, there's a link, an event to procedure there. So just look around the help system and you'll be able to find lots of useful information. If you're struggling with a particular thing, you might find it in the help system. Okay, case number 5. We have a patient who is admitted on September 10th and underwent a hemicolectomy with a wound class equal to 2. On 9/13, the temperature is up to 38.7 degrees centigrade, and the patient has abdominal pain. An ultrasound shows abscess along the abdominal wall. On 9/14, incision and drainage of the abdominal wall abscess is performed, and the abscess specimen is collected for culture, and antibiotics are started. On 9/18, the patient's discharged from the hospital on oral antibiotics, and the abscess culture comes back positive for E. coli. What type of SSI does this patient have? This is a voting question. A SIP, a DIP, an IAB, or a GIT? Oh, they don't have the answer. Oh, yes. Okay, a couple more seconds. Okay. So the correct, all right, so 74% of you thought it was an SSI IAB, and 22% thought it was a deep incisional primary, and someone thought that it was a superficial infection. So the answer is an SSI IAB, and let's look at why that's the case. So I just want to point this out. This is one of those slides that I messed up. It's correct here, but when you get your answer sheet, this one's going to have the mismatch of the deep incisional stuff in this area. Okay, so sorry about my poor cut and paste job, but this slide is correct, and it's just the same thing as the other one that we showed you already. So for this one, we said it was an SSI IAB. With this patient had a colo, and so we only have to follow it for 30 days for deep incisional and organ space infections. And this is an organ space within 30 days. It did involve the organ space site, not the incision. And we had organisms isolated from the abscess. Remember, that was during the IND. And we also had an abscess that was discovered during an invasive procedure. So it met more than one of the IAB criteria. And it also meets the IAB criterion, which is shown here on this slide. So that criterion 2 of IAB is abscess seen during an invasive procedure. Okay, so remember, for all SSI organ space, you have to meet both the organ space criterion and the specific organ space site criteria, in this case, IAB. And that's essentially what this slide says. Okay? So any questions about that? Now, I think you may have noticed, those of you, since you all should be used to doing SSI surveillance, that for 2013, we've added this little piece at the bottom, just to be, because there were some people that were confused about having to meet that extra criterion of the specific site of the organ space, infection. So that's now included as part of the organ space SSI criterion itself. Okay? So it's nothing new, it's just we've written in what we probably should have had there all along. Okay? So why didn't we choose GIT as the specific site? Now, I know you don't all have Chapter 17 in front of you. But the reason is because the abscess is in the abdominal wall, and the specific site, GIT, or gastrointestinal tract, focuses on infections in the organs of the tract. Okay, so the infections in the peritoneum or in the space are what we use IAB for. Okay, so we get questions on that from time to time, and I just thought I'd mention it here. Okay. So now I'm going to change the scenario just a little bit and say that at the time of the IND, it was discovered that the patient had suffered an anastomotic leak from which the abscess developed. Does this change your determination of it being an SSI IAB? This is just to shout it out. So I hear no and I hear yes. Okay, the answer is no. Remember, this is after the fact. This is a patient who had the surgery and everything was fine, and then later developed the leak that led to the infection. So it's a complication of that surgery, and therefore we would call the SSI. All right? So it's a different case than the case of the patient that comes in already infected and then has the surgery. Okay? This is really a complication. Okay? Does that make sense? Okay. All right, case number 6. On January 22nd, we have a patient who had an abdominal hysterectomy, or a HIST. On February 1st, a patient has pelvic pain and a temperature of 38.4 degrees centigrade. On February 2nd, the MRI reveals an abscess in the deep pelvic tissue. And on the 3rd, the surgeon opens the wound in the OR and drained the abscess, sent the specimen to the lab for culture, and notes infected hematoma, and antibiotics are begun. On the 5th, the culture comes back positive for Pseudomonas aeruginosa. This is a voting question, and what do you think should be reported? An SSI IAB, an SSI OREP, or other reproductive tract, or an SSI EMET, endometritis? And again, to really do this right, you need to look at all the criteria to figure it out. But take your best shot. All right, are you about ready? Last chance. Okay. Okay. So we got a difference of opinion here. Most of you said an IAB, and a number of you also said OREP. So let's find out who's correct. Yay! All right. So why isn't this an IAB? An IAB definition says intra-abdominal, not specified elsewhere, including gallbladder, so it only includes gallbladder, bile ducts, liver, spleen, pancreas, peritoneum, subphrenic or subdiaphragmatic space, or other abdominal tissue or area not specified elsewhere. So guess what? We do have one that's specified elsewhere, and that's OREP. So OREP is for infections. So it's a bit of a nuance, and I just wanted to point that out to you since you are doing, you may run into this with hysterectomies, that you should be looking at OREP as a site sometimes. It may not always be the site of an organ space infection, but it may be. So this case, it meets OREP criterion 2, where the patient had an abscess seen during an invasive procedure. Okay? Now, this is one of the areas that we're thinking about simplification, all right, for the future, of not really going to this level of discrimination. So that's something we'll be talking about with the working group, and hopefully maybe by 2014 or we can simplify some of the criteria so that there aren't so many and you don't have to get to this level. But for now, this would be the right way to report this. Okay? All right, let's do case number 7. On day 1, hip arthroplasty, or an H-PRO, was performed, and the patient was screened for MRSA upon admission to the ICU per the ICU's protocol. On day 2, the patient is very confused, has a temperature that's normal, and the wound condition is looking good. On day 3, the results of the admission screening cultures of the nose and groin are positive for MRSA. The following entry is found in the chart. Patient removed the dressing several times. Recurrent confused condition. Wound edges are very red and taut. On day 5, the entry in the chart says, wound abscess lanced by the attending surgeon, a wound specimen sent to the lab for culture, and antibiotics were begun. On day 7, the wound culture was returned positive for MRSA. On day 9, there's been improvement in the condition of the wound, and the patient is discharged to the rehabilitation center. Does this patient have an SSI? This is not a voting question. Yes. This patient's incision was red at the time he was pulling the dressing off. So, we don't give the surgeon a pass because the patient was messing with the incision. Okay? What type? Superficial incisional, yeah, and at the primary site, I heard someone say. And what do you think the date of infection is? Day 3. Great, perfect. We need that 100% here. Very good. All right, let's do case 8. We have a patient that had a 2-vessel CABG performed using a saphenous vein, which was harvested via a laparoscope, and an internal mammary artery. The ICD-9-CM procedure codes assigned by a medical records coder were 36.12, which translates to a CBGB, and 36.15, which translates to a CBGC. What NHSN operative procedure code or codes should be entered into NHSN? Only a CBGB. Remember, that's the exception we talked about earlier today. Very good. So here's the rationale from the denominator data reporting instructions, where we've got the exception about the CBGB and C occurring on the same trip to the OR. We only want you to report it as a CBGB. Now, should you report that the scope use was yes or no? Yes, that was another exception we talked about. So usually we say the entire procedure, but for CBGBs, if they use a scope to do the harvesting of the donor vessel, then we just go ahead and say yes. All right? So very good. You were paying attention. And here's the rationale and where you can find it in the manual. All right? Now, what if the patient develops both a leg donor site superficial incisional infection and a chest superficial incisional infection? Do you count 2 infections or only 1? And if only 1, which one? How many say 2? I'm hearing 2. All right. So does that mean the rest of you say 1, or are you just abstaining? Okay. So the answer is 2. Right? You count the infection at the chest as the primary site, so an SSI SIP, because the primary site is the chest incision, and then you count the donor site infection or the leg incision infection as an SSI CIS, a superficial incisional at the secondary site. Okay? Does that make sense? So a patient with the CABG can have more than 100% infection rate, right? So that is the way it's counted. Okay. So it's the rationale, again, because there is an infection in 2 different operative sites of the CABG, we have 2 separate SSIs that have to be reported, and each of those would be linked to the same CBGB. So when you enter the SSI for the chest infection, the SIP, then when you link it, it'll link to the cabbage. And when you enter the SSI for the cysts, the secondary at the donor site, you link it also to the cabbage. Okay? So you can link more than one infection to an individual operative procedure. Okay, this is the last one for me, and then I'm going to turn it over to Gloria with the last 9. All right, case number 9. On May 15th, a 45-year-old female undergoes an abdominal hysterectomy, or hyst, and a colectomy, or colo, performed through the same incision. If both of these procedures are in your monthly reporting plan in May, which they should be for all of you, which one or ones do you enter into NHSN? How many of you say both? How many of you think it's not both? 1, 2, okay. Couple, 3. All right, and the answer is both, right? Because this is that rule we talked about. If procedures in more than one operative procedure category are performed through this during the same trip to the OR, through the same incision, then you're going to have a different record for each. Okay, so we have one incision where they've done the hysterectomy and the colectomy. You're following both of those in your plan because you're reporting for CMS. So you're going to have a hyst record, a colo record, and then if the patient gets infected, we have to deal with that separately, right? How would you do the durations for these procedures? Right, so we're going to, if you have more than one operative procedure category, which we do, performed through the same incision during the same trip to the OR, then you take the combined duration of all the procedures, which is the time from incision to closure. So they'll each have the same duration. Each record will have the same combined duration. Because you only have one incision, right? So it makes sense. It's only going to be one cut and one close time. Okay? Does that make sense? How many of you have already run into that situation? Yeah. We've heard. All right. So let's continue this one. On May 15th, I'm just repeating this scenario here. She had this hysterectomy and colectomy. And so that was her procedure date. And then on the 19th, the patient spikes a temperature to 38 degrees centigrade, has abdominal pain and emesis. An ultrasound shows fluid collection in the abdominal cavity. A fluid specimen for culture is obtained by needle aspiration. And on 5/20, that culture is positive for E. faecium with many neutrophils seen. Is this an HAI? Okay, absolutely. And you can guess what the next question is. Is it an SSI? And if so, which one of these do you think it is? Is it a deep incisional primary, a deep incisional secondary, an organ space SSI at the IAB site, or it's an IAB but there's no SSI? So this is a voting question. Okay, a couple more seconds. All right, last call. All right, we're going to close the polling. So 81% of you, most of you said that you thought it was an SSI organ space at the IAB site, and you would be correct. Yay! All right, doing great. So the next question is, to which procedure is the SSI attributed? We got somebody anticipating my questions. So this is a voting question, I think. No, it isn't. No, it's not really a voting question. So which one do you, how many of you think it should be attributed to the hysterectomy only? How many think to the colo only? Okay, that's most of you. And how many think it should be to both? Nobody. All right, well, excellent. Yay, give yourselves a pat on the back. And again, let's go over the rationale for why this is the case. So remember we said that if a procedure from more than one NHSN operative procedure category was done through a single incision, in this case we do have a colo and a his through a single incision, then you attempt to determine the procedure that is thought to be associated with the infection, and sometimes that's clear, and more often than not it's not clear. So if it's not clear, then you need to use the principal operative procedure selection lists in Table 5 to select which procedure to report. And if you look at that, you'll see that, and this is the new one, this one you don't have yet, but for 2013 it's going to look like this, and it shows that colo comes before hysterectomy. In fact, that's the same as it is now, but this list is the new list. All right? So colon takes precedence over hysterectomy, and so you would report it to the colon. Okay? Does that make sense? If it doesn't, are you willing to accept it? All right, I'll take that as a yes. All right, I'm going to turn it over to Gloria. We've got 9 more to do. You're doing great. And hopefully we'll have time, get you out on time, but also be able to take questions.
Okay. All right, let's take it away with case 10 on January 22nd. The patient had a total laparoscopic abdominal hysterectomy. On 2/1, the patient had abdominal pain with purulent drainage in 2 out of the 3 trocar sites. Our temp was 38.4 degrees centigrade. 2 days later, the surgeon opened wounds in the ER and noted purulent material in the fascial layer. Specimens sent to the lab for cultures and antibiotics were begun. On 2/5, cultures were positive for Pseudomonas aeruginosa. Is this an SSI? Okay. And this is not a voting question. So, yes, you got it right. What type? How many say superficial? SSI. How many say deep? Okay. Deep incisional primary, very good. And let's look at our rationale here. For deep incisional SSI, the infection occurs within 30 or 90 days after the operative procedure according to Table 3. It involves the deep soft tissues of the incision, for example, fascia and muscle layers, and in this case, we have purulent drainage from the deep incision. So all criterion are met. This is a voting question. How many surgical site infections should be reported in this case? Okay, go ahead and start voting. Yeah. It won't be there. Okay. Okay. Okay, I'm going to close voting. Let's see what the answer is here. 95% of you said that only one surgical site infection should be reported. 4% of you said 2, and I think one person may have said 4. The answer is 1. Okay, and we talked about that earlier, that even though there's more than one trocar site, it's still going to be only one surgical site infection. Following laparoscopic surgeries, if more than one of the incisions should become infected, only report as a single SSI. If one is superficial incisional and one is deep, report only as deep. And this is our numerator reporting instructions in Chapter 9 SSI. Now, some of these reporting instructions that we're talking about today actually will show up in the new manual, okay? But some of these have been around for a while. Okay, case 12. A male patient underwent a K-Pro in April of 2010. In October 2010, the prosthesis was removed due to an unresolved infection in the joint space with MRSA. A spacer was placed and a replacement procedure was scheduled for the following February 2011. The replacement K-Pro was completed in February 2011, and within 3 weeks after discharge, he developed osteomyelitis with MRSA near the attachment site. How should this osteomyelitis be reported? And this is a voting question. It's linking. Okay. It is over. Mm-hmm. Okay. 2011. Okay. Okay, our answer is 82% of us say the SSI is linked to the February 2011 operative procedure. Okay. And the answer is the SSI is linked to the February 2011 operative procedure. Very good. And our rationale is, if a patient has several NHSN operative procedures prior to an infection, report the operative procedure code of the operation that was performed most closely in time prior to the infection date. Okay?
I have a question back on that other case. Not to, I mean, I'm reneging on my own answer here.
Okay. This one or the one before? 11?
Case 11. Okay, you've got purulent drainage underlined, but then in D, or in...
Oh, that's a type of, that's a spelling.
No, in C it says, an abscess or other evidence of infection involving the organ/space that is found on direct examination, invasive procedure, or by histopathologic exam or imaging test. Patient had an abscess seen on a gallium scan. Would that qualify for imaging test?
Yes.
So it is an SSI.
Well, it is for 2012, but remember, because we've gone over the 90-day period for this type of surgery in 2013, it would meet criteria for SSI, but it actually will not be counted because we only track them for 90 days.
Okay, but we might, I mean, I know that's not clarified on here, but if people are going to have to be thinking about that, are you answering this? If we're going back to educate people, we need to know, are these answers geared towards 2013 or 2012?
Well, like we said, in this case, this is correct for 2012, but because we extended the time frame from previous lectures, then for 2013, this patient will not be reported in NHSN because the infection was identified greater than 90 days.
I'm just suggesting that on the slides, if you're going to use these slides again, you might add what you have affirmed verbally, because it's not on the slide deck.
Oh yeah, we just found it out right now. That's what I was saying. So thank you. Okay. Let's see. All right. Okay, we have case 13. The patient had an OREF, an open reduction external fixation of the left tibia on November 12th. His course was uneventful, and he was discharged on November 20th. He was readmitted on December 3rd with purulent drainage, growing MRSA from the proximal pin site, which is not contiguous with the incision, and with a matching positive blood culture. Okay, this is a voting question. What should be reported? SSI, superficial incisional primary with secondary BSI. Number 2, primary BSI. Number 3, SSI, superficial incisional primary only. And 4, none of the above. Okay, I'm going to close the voting. Let's go ahead and, if you're going to click, go ahead and click now. Let's see what the answer is. Okay, 61% of you said it is none of the above. I think one of you may have said this is a superficial incisional SSI primary only. 21% said this is a primary bloodstream infection, and 17% of us said it's a superficial incisional primary with a secondary BSI. And the answer is none of the above. Okay, and why? The rationale is this infection is at the pin site and not the primary incision. Therefore, this does not meet criteria for a surgical site infection, SSI incisional primary. Okay, the positive blood culture may make you suspect osteomyelitis, but the organ space SSI criteria are not met. The pin site infection and BSI occurred more than 2 calendar days after discharge, therefore they cannot be associated with the hospital stay, i.e. not HAI. Okay? So remember, a pin site infection is not an incisional infection per NHSN. It can be considered skin and soft tissue, but it's not the primary infection. All right? Okay, case 14. A female patient underwent a K-Pro, a total knee replacement operation on December 22nd, 2010. She returned to her surgeon on January 31st, 2011 with purulent drainage from the superficial incision, which had started 2 days prior. How should this infection be reported? This is a voting question. Is this a superficial incisional primary SSI? Is this a deep incisional primary infection, or is it organ space? Or this should not be reported. This event does not meet criteria for SSI. A couple more minutes. Okay, I'm going to close voting. 86% of you say this is not reported. It does not meet criteria for SSI. 13% of us said this is a superficial incisional primary SSI, and 1% said it's an organ space infection. And the answer is this is not reported. It does not meet criteria for SSI. The rationale is the onset of infection was greater than 30 days post-op, therefore we cannot report it as a superficial incisional SSI. Okay, case 15. We have a spinal fusion patient seen in the ER 11 days post-op with large cellulitis. Pain level is 10 out of 10. We have swelling, tenderness, and redness. The patient was admitted for treatment with antibiotics. He had leukocytosis and an elevated CRP of 199. Serous drainage was identified from the incision and had no growth. Is this a superficial, incisional, or deep incisional SSI? This is a voting question. Number 1 is this is a superficial incisional SSI. Number 2, this is a deep incisional SSI. Number 3, neither. The surveillance criteria for SSI are not met. Okay, go ahead and vote if you're going to vote, because I'm going to close voting. Okay, let's see how we did. 88% of us said the answer is number 3, neither. The surveillance criteria for SSI are not met, and the answer is number 3. Okay? Let's see our rationale here. You can see that of the criterion that are appropriate for this case, we did not have purulent drainage from the superficial incision. We did not isolate organisms from an aseptically obtained culture, and we do not have a diagnosis of a superficial incision by the surgeon, and C is really not appropriate in this case. So we do not meet criteria for SSI. Okay, case 16. This is our last case of the day. On 1/6, the patient underwent a colon resection. Perforation of the bowel was identified, repaired, and the abdominal incision was closed primarily. A colostomy was formed at that time. On 1/23, the patient experienced purulent drainage from the abdominal incision extending to the fascial layer. An aseptic specimen was obtained during a follow-up visit that day with her surgeon, which grew E. coli. Is this infection reportable as an NHSN SSI procedure? This is a voting question. The first question is no. This is not considered an NHSN procedure. 2, yes, as a superficial this is a superficial incisional SSI at the primary incision. 3, yes, this is a deep incisional SSI at the primary incision. Or 4, because both sides are not infected, this infection is not reportable. Okay, I'm going to open up polling, so let's go ahead and vote. Okay, let's do a couple more seconds here. And I'm going to close voting. Let's see what the answer is. 88% of us said this is a deep incisional SSI at the primary incision. A few of us said no, this is not an NHSN procedure. And 8% said yes, this is superficial SSI at the primary incision. And the answer is this is a deep incisional SSI at the primary incision. And the reason we went ahead and showed this case is because we do get a lot of questions about this. The rationale is the whole purpose of this surgery is to create a colostomy, okay? And generally, a colostomy appears to be open, but in reality, when they create it, there's stitches around the colostomy itself. But most of the time, there is a primary incision when the colostomy is created. So the primary incision is generally closed. If that incision is closed, then you can count this as a colo in NHSN if criteria are met. Okay? Okay, we're going to come up and